Excellent. Good afternoon, everyone. My name's Richard Taylor. I'm a GP based in Geraldton, and Mariam and myself have been the RACGP representatives working on the Health Advisory Working Group with WA Police on firearms assessments for the past couple of years. Today, we've been asked to have a little bit of a chat to everybody about the Firearms Health Assessments and where we're at in the current state of play. So Mariam will give a brief overview of the process, and then we'll go on and talk about the early WA experience, some of my experiences at our practice, and I guess some of the issues and the things that we've come across in the process. So before we start, though, I just wanted to do an acknowledgement of country. So I'm based in the Geraldton in Midwest, so that's Yamatji land. So the RACGP acknowledges the traditional custodians of the land and the waterways in which we work and live. We recognise their continuing connection to land, water and culture, and pay our respects to elders past, present and future. I'd like now to introduce Mariam, who will talk to us a little bit about the role of the RACGP WA in this process and the process of the Firearms Health Assessments. So over to you, Mariam.
Thank you very much, Richard. I hope you can all hear me well. I'd like to thank Richard just to begin with. When we started this process, the RACGP was approached in late 2022 when we were notified that the 1972 Firearms Act was going to be revised, and part of that revision was a mandatory health assessment to be undertaken by existing firearm authority holders and new holders. There was some degree of alarm, and the RACGP was approached to become involved and give input into developing guidelines, but also into the Firearm Authority Health Assessment itself. As a Metro GP, I was quite concerned that we really didn't have any rural involvement. Initially, we had representatives on the working group from the Department of Health, the departments and from the Ministries of Health and Police. We had the Royal Australian College of Psychiatrists, WACS, WAFA, and the Mental Health Commission. Subsequently, I think in mid-2024, the AMA started to participate as well. But as a Metro GP, my main concern really was not only developing the guidelines and ensuring that this was going to be workable for GPs. Really, my concerns were for the GPs in remote and rural WA and the impacts that this would have on them and their patients. So our main concerns that we brought to the table were the medico-legal considerations, confidentiality, and the impact on the doctor-patient relationship. That last one, the impact on the relationship, really is unique and special in rural and remote areas, and the impact on rural GPs is, it can be considerable. So the RACGP approached Richard, who was on council at the time, and Richard agreed to become involved, and he's been invaluable and really has advocated for rural and remote GPs in WA. So we'll go on to the next slide, Richard. The firearms application process, it is a significant responsibility, firearm ownership, and I'll just go off camera now. But the Minister for Police and for Health has sort of reiterated it's a privilege that is conditional on the overriding need to ensure public safety, and that safety is improved by the safe and responsible possession, carriage, use, registration, storage and transfer of firearms. So a person needs to be deemed suitable and appropriate, fit and proper. Fit and proper, there are several things involved in that, and the Firearms Authority Health Assessment, or examination as it may be called, is only a part of that. So it's important to remember that doctors are not the final determinants as to whether someone is fit and proper. That final determination lies with WA Police and with the Commissioner. So we have to acknowledge that some medical conditions, disabilities and medical treatments can compromise the ability to safely possess and use a firearm. So therefore, it was determined that Firearm Authority health assessment was needed to ensure that a person's health status did not adversely affect their ability to safely possess and use a firearm. So can a person, or does a person, have capacity to continuously, safely and responsibly possess and use a firearm? Do they have capacity to continuously comply with the conditions of the authority itself and to meet the requirements, including safe storage of the firearm and security? So it is important to refer to the guidelines. So the guidelines are still being reviewed. This was, aside from the development of the health assessment forms itself, it formed a huge part of our advocacy on behalf of GPs in WA. So we have and will continue to work hard on revising the guidelines so that they can be used not as a prescriptive checklist or a set of mandatory criteria, but form a structured framework to support your professional judgment. We must always remember that there are individual circumstances, clinical contexts, and functional impacts that will vary between applicants. GPs are well used to assessing patients for many, many things, including driver's license. And we are best placed to know our patients and to have some degree of understanding as to their capacity to, in a medical and mental health sense, to own and operate and store a firearm. So it's important to recognise that this document is guidance rather than standards. We were very careful to remind WA Police that if we are certifying someone against standards, those standards must be very, very clear, and there may, we were worried about the legal context of having standards. So the guidance notes are more of a provision of context, and you do not have to, it's not a tick box. You can use the guidance notes to come to an understanding of which aspects of physical and mental health may have an impact on that patient's capacity. We are, again, I'll reiterate, we are not the decision makers as to an individual's suitability to be granted a firearm authority. And this is only one component of the overall firearm licensing process. So prior to the medical appointment, a person will need to obtain the firearm health assessment form on the firearm licensing portal. They develop an account and there's an editable PDF. So this is part A, a self-assessment questionnaire, which they complete. Then they arrange an appointment with the health practitioner of their choice, advising that the appointment purpose is for a firearm health assessment or examination, whichever it is to be called. They will email that copy to the health practitioner and print a copy for themselves and or save a copy to their computer. So they must bring a copy of that to their health assessment on the day. This form is not submitted or received in the licensing portal, and WA Police has no access to this part of the assessment. It's not dissimilar to what you might see when a patient has their driver's license, the part that they fill out first. Then, so to the next one, Richard. On the day of the medical appointment, they should bring any prescribed medicines. They need any hearing aids, corrective lenses, contact lenses, glasses, any prostheses if they're wearing them, and they should bring in Part A of the firearm health assessment. So our responsibility then will be to complete Part B of the examination and then submit that outcome once we've done Part C, but I'll get onto that. Just quickly back to the guidance notes. So before we get onto the forms, the guidance notes will give you some information about the tasks involved in the safe handling of firearms, what we might expect. especially in terms of physical and mental attributes required in using a firearm. So the medical criteria of that section does go through quite a few of the mental functions, as they call it. So intellectual, attention, memory, psychomotor, ability to lift and carry objects. Then in part of it, there's the mental health and disability considerations, and especially when there may be elements of dementia, substance misuse. And then the substance misuse, there's section 4.4, looking at impaired perceptual motor speed, visual searching and executive functioning, and then some physical health considerations. So on to the next slide, Richard. So it's really important that all health practitioners, and I think for the most part, this is going to be GPs, you complete and then submit Part C to WA Police Force. This is the only part of the Firearm Authority Health Assessment that will go to WA Police. So Parts A and B are kept in your notes. And it's really important because most of the MDOs are saying you should really retain a copy of Part C and any related assessment documentation in accordance with your usual clinical record keeping practices. So do not submit Part A and B. And in fact, through the portal, you can't do that. And onto the next slide, Richard. So once it's been submitted, you aren't actually obliged to contact the patient or the WA Police Force Licensing or Enforcement Division for any follow-up in relation to the submission of Part C. If WA Police Force requires additional information to inform the decision, this will be requested through statutory processes. You're not obliged or required to provide additional clinical information beyond the outcome in Part C. If you do provide further information, if you choose to do so in accordance with your professional judgment and any applicable legal obligations. And the next slide, Richard. So if you can see, it's a bit squashed in. So there's information for the patient on Part A. So this part is really about their health and well-being. And this one is done by the patient, printed off, and we suggest you store it in your notes. On to the next one, Richard. So Part B is your assessment. So the health assessment and pretty much vision and hearing, any neurological symptoms, physical health. And if you've ticked yes in Part 4, you're going to perhaps have to put some relevant details. The parts, a lot of this, we worked really, really, really hard with WA Police Force because we were conscious that it's very, very difficult for us to determine much of this and to put ourselves in a position where it may be, as many GPs were worried, used against them in court. But Richard will talk about the civil and criminal protections that are afforded to us. And so on to the next slide, Richard. So if you've got people over 80, they're going to need this done every year. So for everyone else, it's 5 yearly or on your first application. So for people over 80, we suggest that you take a look at the guidance notes. If you have any concerns about cognitive capacity, using the validated screening tools, and there are particular things that you may consider, just as you do for people over 80 with the driving licence, but bearing in mind holding a firearm, using a firearm and storing it is it's quite difficult to assess for many of us. But it's to remind you all, it's a here and now on the day to the best of your knowledge that the patient presents to you. And the next slide, Richard. So Part C, this is the determination. So this bit is provided to the Commissioner of Police. Remember, it is in good faith. It does not give rise to civil or criminal liability. We laboured that point for nearly 3 years. We've worked hard. It is written in the documents, and when we appeared in front of the Legislative Committee last September, we reiterated this so that it was documented. You can only give the information on Part C that is provided to you by the patient. If you're not familiar with the patient's history, you are not obliged to do the health assessment, and you can only use what is given to you. It is a point in time. Circumstances may change, and we have worked hard and advocated so that WA Police know that as GPs, we are not proxy decision makers. We cannot look into the future and predict future harms. So you then submit Part C to WA Police. And next slide. So this is the health assessment outcome. Unfortunately, you do have to, through the portal, provide your APRA and date of birth. We didn't want that. We thought there were, well, a potential for breach of privacy, but WA Police, despite our protests, it has still remained. So those things will need to be put through the application license number and the passcode that the patient will be given, and then you submit this part. So we did try to remove the part that says a standard, because formal standards have not been written, but we spent about 18 months fighting this. But it still remains on there. But remember, you're not obliged to do this assessment. It is a point in time. Use your clinical judgment, and it is based on the available clinical information at that time. So that's an overview. And next slide, Richard. So I think I'll hand over to Richard now, and he'll talk to you some more.
Perfect. Thanks, Mariam, for the overview of the process. I just want to talk now a little bit about the GP experience to date. So the college sent out a survey earlier this year, and some of you online might have actually completed this survey. Really, the aim was to capture those early experiences of GPs in WA with doing the firearms assessments. And just as, I guess, a bit of a summary, we got 81 responses back, and of those 81, about 60% were asked to, or well, had been asked to complete an assessment, about 40% hadn't. So of the 32 GPs who were asked to complete a firearms health assessment, the vast majority of them were actually rural. So 2/3 of them were rural, and the other third were either practicing in a metro or an outer metro area. And another really interesting point was that about a quarter of these assessments involved non-regular patients. So really, a lot of these applicants weren't familiar to the GP, and we'll talk a little bit about the ramifications of that a little bit later. Looking at the GPs who decided to complete the assessments, basically two-thirds of GPs completed and 1/3 declined. But if you actually drill that down and look at rurality, so rural GPs, 80% completed the assessments and 20% declined. And so I think, for reasons we'll go on to as well, rural GPs are more likely to be exposed to and to be actually completing these assessments compared to their outer metro counterparts. So I guess in terms of some of the difficulties and the common issues that were identified, a lot about really the documentation and the logistics. So confusion around the requirements to complete Part C online versus the written format. How do you submit? A bit of ambiguity, in fact, a lot of ambiguity around assessing mental fitness and what that means. And then difficulty where you don't have all the information. So if you don't have specialist documentation, such as psychiatry letters, where that leaves you and how you actually complete these assessments. In terms of reasons for declining assessments, all sorts of different reasons, and remember that this is not an obligation. You are well within your rights to decline completing assessments. But often the reasons included discomfort around the level of responsibility associated. So that I guess the high stakes involved with certifying somebody fit to hold a firearm license, and also sort of an unfamiliarity with using a firearm. The difference between this and driver's license assessments is, we all drive cars. We're very, very familiar with the process, but not many of us hold firearms licenses. So unfamiliarity is something that a lot of us face. An inability to proceed ethically, so conscientious objection, and also clinically, if you don't know the patient very well, or if you don't have access to the records, then that's another reason for declining assessments. Some GP practices choose not to undertake firearms assessments. So I've heard of whole practices, sitting down as a practice policy and just deciding, what, we don't want a part of this. And that's an absolutely reasonable approach to take as well. And so some practices just won't do these assessments. And then some GPs as well, they don't do any assessments, altogether. One GP stated they didn't do driving license assessments, and they weren't willing to do these either. Lack of specialist information is another reason for declining assessments. And on one occasion, an applicant didn't actually want to pay the fee to have the assessment. An important note to make is that these assessments aren't actually covered by Medicare, much the same as driver's license medicals, and there is a private fee that you need to charge. Broader concerns raised by GPs, and a lot of these would be familiar to a lot of us. The concern about it impacting the therapeutic relationship. So, if you've got a long-term relationship with a patient, being very, very reluctant to disclose physical or mental health concerns because they're worried it might impact their ability to obtain a firearms license. And that's a real legitimate concern for people. The role feeling administrative, so very much the police department pushing this upon GPs and diverting time and focus from what we do as GPs is a big concern. Medico-legal exposure. Big concerns regarding that, reputational risk and the emotional toll of doing these assessments, and also the fear that adverse outcomes. So, clearing somebody for a firearm and then, heaven forbid something happening, the impact of that in terms of your public scrutiny, coronial process, and the worry that this is potentially a career-ending decision for clinicians as well is another big concern that we all face and we all have. As a rural GP, I just wanted to talk a little bit more just about the rural context as well. And I suspect most of us online are probably from a rural areas. Impact on workload isn't significant. I was actually really surprised to hear as part of this process that there are 90,000 licence holders in Western Australia, so 90,000 people with firearms licences. And 53% of these reside outside of the metro area. So it does actually represent a big workload on GPs in rural and remote areas in an environment that we already know we're really stretched and under-resourced as it is. So the workload isn't insignificant. The other concern in a rural setting is the closer association between a firearms licence and somebody's employment. So certainly in a rural setting, firearms licences are more often linked to employment. So thinking particularly primary producers, so farmers, people are involved with vermin eradication as well. So there are a higher amount of people out there who do rely on their firearms as part of their day-to-day job. Confidentiality is obviously another big issue in a small community, and the impact of these assessments, in a smaller community as well. We've already touched on, and this came through in the RACGP survey, the impact on the patient-doctor relationship and the avoidance of health seeking, and the willingness of the firearm holder to seek mental health assistance. And also, thinking about the cohort that we're trying to engage traditionally can be a tricky cohort to engage at the best of times. So pushing them further away from seeking help is a really, really big concern. And then finally, the pressure on GPs in remote communities. So it's all very well for you to say, don't want to participate in firearms licenses, but certainly if you're the only GP in a community, there's going to be a much higher pressure on you to perform these assessments. You can't just tell the applicant to go down the street to the next GP because you might be it. So certainly feeling the pressure in those smaller communities. I just wanted to go through now, I guess, a little bit of some practical cases. These are actually from our own practice in Geraldton, and some of our own experiences. And be very interested to hear if other people have some similar stories to share. But just really a few cases, just to sort of highlight some of the challenges that we're coming across, and that you probably have as well. So the first case is a case of one of my colleagues, and he's a new patient, which is already a little bit of a flag, so somebody that we don't know, and he presents for a firearm renewal. And he actually presented with a letter from the police commissioner that his firearms licence had been suspended and that a health assessment was required. And that's already a flag right there. So this isn't actually a renewal, this is actually a suspension and a request for a health assessment based on a suspension. So the GP involved did a little bit of digging and found a little bit of further history and found that there was some previous drug and alcohol related offences, and the GP felt quite uncomfortable and said, well, actually, you know what? No, I don't want to complete this assessment. This isn't something I feel comfortable with. The applicant then tried to bribe the GP, who refused to pay for the consult, as the health assessment hadn't been completed, and this was 45 minutes of the GP's time. So obviously a very, very frustrating consult. The story does get better. So the applicant then went on to another practice requesting a firearms health assessment. It was actually seen by a GP registrar who contacted her supervisor. Now, we were really, really lucky in this case because the GP and the supervisor actually had access to the previous GP's notes, and the candidate wasn't deemed fit to hold a firearms licence. Second case. So this was another new patient. So again, a little bit of a red flag. Presents for a firearms renewal. Yeah, I see your hand raised up, Paul. I might take questions a bit if that's all right, because I think this will generate a bit of discussion. Again, this chappie, firearms suspension. Background of a previous episode of psychosis and self-harm, but had actually been seen by a psychiatrist who had cleared him previously. The current suspension was in place because there were concerns about domestic violence. And again, on this occasion, the GP didn't feel comfortable completing the health assessment and recommended a psychiatry review as well. So look, these cases were pretty extreme, but the reason why I've shared them is that they're real cases, and they do highlight some of the difficulties with performing the firearms assessments. And look, really, I think for the most part, a lot of these assessments are quite straightforward, but the tricky situations arise when you actually don't know the patient's history. And both of these cases were new patients and they weren't known previously to the GP, which does raise issues. And look, I think the bottom line out of all of these scenarios is if you're a GP or a GP registrar, if you're not sure, phone a friend and ask for help, as we normally would in these situations. Just going through a few slightly more straightforward cases. So these are my own patients. So case 3, a 75-year-old retired farmer. He's a regular attender at a GP practice, and he presents for a renewal of his firearm licence. I've been looking after him for the better part of probably 10 years now. He's got a background history of reactive depression following the death of his wife 5 years ago, and he's on sertraline. He's otherwise very well, very stable, engages with me regularly. There's no history of self-harm or suicidal ideation, and certainly I had no concerns at all with completing his firearms health assessment. It's actually really interesting because in the early days of the Hawg, one of the questions raised was around the mental health fitness and, what happens if somebody has depression? Is that something that needs to be declared? Are they fit to hold a license or not? And one of the police representatives turned to me at the time and said, "Well, if that was if that was an exclusion from holding a firearms, then you've probably lost half of the WA police force." So again, I think it's that clinical judgment as well that plays a part in the decisions that we make. The fourth case, so 67-year-old truck driver, and he's a member of one of our local gun clubs. And he presents as well for a firearms renewal. I looked after him for a number of years. He's got a background of hypertension. He's got type 2 diabetes. He's on a GLP-1 agonist, SGLT2 inhibitor, metformin and olmesartan. From memory, I think his HbA1c is something like 6.1%, and his hypertension is well controlled. And he's recently passed his commercial driving medical. Based on that, I had no concerns at all as well with issuing him a firearms, putting in a firearms health assessment for him. And then the fifth case. So this is a 68-year-old. He's got a new diagnosis of Parkinson's disease. He owns a little hobby farm outside of town, and again he presents for a firearms renewal. He's known to a consultant neurologist and is on Matapar for his Parkinson's disease. He is in a position where he feels safe to hold a firearm at this point in time, but we suggested for him, rather than a 5-year review, maybe we put a recommendation of a review in 12 months, just to assess where his Parkinson's disease is at and whether we still feel that he's safe to still hold a firearm. And we're able to do that as part of our recommendations. We can say, well, look, recommend a review in 1 to 5 years as well. And again, that's I guess a clinical judgment in many ways. So just talking about what we do in our own practice in Geraldton, and some of the processes that we've put in place, just from our own experiences. I do believe that the usual GP probably is the best person to complete a firearms health assessment, because we actually know that patient really, really well, and we know their history in and out. If, though, the usual GP doesn't feel comfortable completing the assessment, then what we do is they then refer to a GP within our practice who's happy to complete the assessment. So we've put that process in place. If it's a new patient, so if it's somebody who's not known to us, we're requesting a history and a health summary from the usual GP or the previous GP if they're coming over as a new patient. And we try and triage these patients, these applicants, before the appointment's made. If the applicant doesn't have a treating GP or has never seen a GP, that we actually ask them to provide their notice number and complete the Part A assessment, that self-assessment, before they make an appointment, because that gives us a bit of an idea of where things are at, whether it's a renewal or whether it's a suspension. So again, those 2 particularly challenging cases were both suspensions, and that just gives us a bit of forewarning as well, and enables the GP to really review that history before seeing the applicant as well, so we don't get caught with any caught on the fly basically. And then at the time of booking, the applicant is also informed that this isn't a Medicare rebatable service, and that the firearms assessment does attract a fee as well, again, so that there's no awkwardness with people not wanting to pay for the assessment as well. So I guess these are the things that we've, as I say, put in place in our own practice, and they seem to work. They seem to work pretty well. Um, I guess through this process, initially when I was asked to sit on the hawk, I must confess I sort of didn't really want anything to do with the process. But then I sort of thought, well, we do need to engage. This is coming through regardless, with us or without us. And really we wanted to try and make the process as painless as possible for GPs. And we got a lot of pushback, and we had some wins, and obviously some things we weren't very successful on changing. But I think that the process that we have is far superior to what we would have had. And I think as well, part of this and part of my, I guess, thought process in this as well is perhaps looking at the opportunities that exist, given that this has come through regardless. And I think part of it, sort of looking at trying to reframe the conversation a little bit, and looking at wider harm reduction, basically, and how we can engage people. And it's really interesting because if you look at the data, obviously there's been some pretty awful high-profile cases in WA in the past 24 months or so. But if you look at the harms of firearms, it's actually suicide by firearm that's the largest cause of firearm-related deaths, certainly in New South Wales. Um, um, that we're seeing. So maybe using this as a means of being able to engage those people is a way that I'm sort of trying to approach these firearms assessments. So what I tell my patients, and it's really, I think, partly about trying to change the messaging and I guess the spin. And so what I tell my patients is that the best chance of them retaining their license is actually to have a regular GP, and making sure that we're looking after their physical health and really looking after their mental well-being, and really using the assessments as an opportunity to engage people who wouldn't ordinarily engage. So seeing these people and saying, well, look, have you done your bloods recently? What are we up to with your preventative health? Have you done your bowel cancer screening, your skin cancer screening? So a real way of actually engaging with people and using it as an opportunity is the way that I'm kind of trying to see these assessments. And again, also trying to link people in with a regular GP who they trust. And we all know that's the power of GP, that continuity of care that we offer, that relationship building that we have. So I think that's my take on a rather imperfect system, really. So as I said, look, I look after quite a few farmers as patients, and you always know where the season's at because you never see them during seeding and harvesting, and then they all come in at once for all their bloods and everything at the same time. But as I say, I do see the Firearms Health Assessment as an opportunity to engage with people. And look, I'm very happy to do assessments on my own patients because I know them. Obviously, a little bit more cautious about people I don't know, and in those situations, I'd be getting a bit of information before I consider doing the assessments. Just to summarise as well.
అయ్యో! ఆ యమ్మకి ఫోన్ చేయమనొద్దురా! ఏమిరా ఏంటిది?
Yep, sorry. All good? Yep. So just to summarize, ongoing advocacy from the college and what we're doing. The guidance notes are still in the process of being reviewed, and that's an ongoing process. Obviously, we're advocating for very clear guidelines as well. And so what we're trying to do is making the system and process safe and workable for GPs who are electing to complete these assessments. Again, there's no obligation to complete these assessments. We're continuing to push to ensure that we've got appropriate medico-legal protections in place. I think that's really important. The other thing that we're doing is advocating, as I say, for clear guidelines and escalation pathways as well. So that's what we're trying to do, Mariam and I, in the background. Certainly, I'd like to open up to any questions or comments or feedback. This is the QR code for the RACGP survey. So if anybody's interested or wants to put in, feedback, their own experiences, and doesn't want to talk today, that's okay. Having that information is really invaluable, because then we can feed that back to WA Police and let them know where they're at. I think we've got time for questions now, and I guess Mariam and I will do our best to answer those questions. I did see a comment in the chat box which was actually put in before, and I'm just going to see if I can have a look at that. Yes. So let's have a look. So questions submitted. So the first question: how are practices managing requests from patients new to the area to have a firearms health assessment? So as I say, we're asking for health summaries, or for them to complete Part A, before they come in. So I hope I've answered that question. How are practices managing requests from patients familiar to the practice but to see their different practitioner due to lack of availability of their regular doctor? Again, we're for those GPs who aren't comfortable completing the assessments, we're allocating to GPs who are willing to complete those assessments. Yeah, my main criticism of the program is it looks like it's a half-assed job. I agree. I would like to see more comprehensive standards, much like Ausroads, and we have been pushing for that. Unfortunately, we have been getting a fairly significant amount of pushback. The guidance notes is probably, to be honest, the best that we're going to get. And again, I think the really important thing to remember is that this is a point-in-time assessment. We've made it very, very clear to WA Police that, we can't predict future risk, and we need. Yep, and we can't predict future risk. We can't do that. So we've got to make the best judgment.
On that note, that's really important to reiterate. It's a point in time. The question regarding if the patient doesn't declare their history, who holds responsibility? We've worked hard on that, and the responsibility does lie with us when we're submitting whether they're fit or unfit. But if the patient or the person goes on to be a perpetrator of a firearm crime, there are civil and criminal protections. None of us want to be scapegoats. We don't want to be in the media. And I think that the nearly 4 years now of advocacy has really brought to the attention WA Police of what actually is involved in doing these assessments as a GP. It was good that we were acknowledged as the experts in holding the knowledge of our patients' capacity and capability, but at the same time, that level of responsibility is a burden. A lot of people within the room, Richard and I were the only GPs in the room, didn't actually understand what's involved in general practice, and even the workings of it, and holding these documents, our medico-legal responsibilities, the time, and for example, the time taken and whether we need a nurse, telehealth considerations, and these can be done by telehealth if needed. And also, what about our GP registrars in remote and rural areas? But as Richard said, if you don't feel comfortable doing it, you do not have to. So we've worked hard for this to be as workable as possible, but responsibility lies really ultimately with the police commissioner. You will just be declaring that this, based on what this patient's told me about their mental health history and their depression, I consider them safe or unsafe on Part C. Then also, if you have that for Part C, if you're recommending that they need to see a non-GP specialist, for example, a psychiatrist, you can put that they are fit, but with restrictions. There's a box on Part C, and you can say sort of that really they need to see it's dependent on them seeing a psychiatrist or having some sort of other mental health input. We did bring to the attention of WA Police that, you know, we can't conjure up psychiatry appointments in a flash. Sometimes it takes up to a year for a patient to be assessed by a psychiatrist. But if you think that they're stable enough, then you could say, look, doesn't quite meet criteria, but with conditions, and then review in 12 months. Or if you think that they really do need to see a non-GP specialist before you feel comfortable certifying them fit, then just say you don't think that they are.
Yeah. And the other thing as well is a lot of people are worried. I've just seen the comment about the criminal history. So the police actually do checks before they even come to you. So they assess whether the person's a fit and proper person to hold a license before they even come to you. So known associates of bikie gangs, for example, all those sorts of things. None of those people should be coming to you for a health assessment because those people should have been screened out. And so bearing in mind that our health assessment goes into the pot with all the other information to determine whether this person is fit to hold a firearm. So it's actually not us saying they're fit to hold a firearm. It's actually us providing effectively a medical opinion, but we don't determine whether somebody has a firearm or not. That's WA Police. So we're not going to be, you know, asked those sorts of questions. The other thing is that there is a helpline that you can contact as well, and I believe that's on the some of the resources which we can obviously send out through Rural Health West. So now I can see that Paul's been chomping at the bit for the better part of a half hour to say something. So Paul, fire away. I don't know. I'm assuming your speakers will.
That should be good. Yes, I was the one who was going on about it's just getting better clarity to the requirements. Why are they pushing back, Richard?
Because they're the police, and they're basically
they don't want to do the work. Is that the main issue?
Yeah, pretty
much.
I
suspected as much.
Yeah,
look, what I also wanted to further go into on that is it strikes me as ambiguous on whether we're meant to be using background information or not. You know, how it goes and says we're definitely not allowed to look on my health record. Is it, you know, how like when you do an employment medical, you're not really meant to look at their past medical history that you've got from other things. It is what they present to you at the time. They sign off that they're not lying to us and everything else. And whereas a driver's license, certainly for private standards, they do expect us to look at their past medical history and all that kind of stuff in those ones. And I feel that it's ambiguous in the firearm one. And yeah, my personal opinion is I actually disagree. I don't think the GP is the right person. I think a colleague who can see your notes is the right person to do assessments, just because that way you take the bias out and everything. But yes, that's where I get hard on it. It's like, well, if I know they're lying to me, you know, that's actually more of a conflict. And then I'll just give one second part. Those two first cases, it's like they've brought in two different assessments at the same time and they get mixed up because the application and renewal of a license is very different to the I've had my guns taken off me. And the actual form they bring is completely and utterly different, and it doesn't seem to have the same requirements to it. So my personal practice is I don't touch them. I actually don't consider them firearm health assessments, the removed license medicals. And the wording on it is impossible for any kind of doctor to ever clear someone. Anyway, I'd like your thoughts on those couple of points.
So the first point, yes, we have worked long and hard on all of this. We've brought so many concerns to them over 3.5 years. The pushback really is with the Minister of Police, and it really was to address the public concerns, I think, really about firearms crimes and deaths. And so that the act was well overdue, perhaps, to be reviewed after 1972, but there's been a push for a medical standard. I think that GPs, we are very, very well placed. We're very good at making assessments and judgments. There's always going to be an element of bias. Use your clinical judgment. It's hard for us to ever sort of remind ourselves, but we are the experts in our patients' care. We know them better than anyone else. And that, for that reason, I think it was good that they actually approached GPs to be involved in the health assessment working group, but also to be part of the health assessment process. But again, through our advocacy, we've ensured that there are the legal protections, and we've tried to reduce ambiguity. Neither myself or Richard are lawyers, we're GPs, and that's our expertise, as is yours. But it can be difficult. We've been, when we took this to the newer Minister of Police last year, we asked about using sort of occupational health physicians or GP specialists in occupational health, and I think that will be an option. So there are some in rural hubs, but again, if it's only every 5 years and they have to go to Geraldton or to Port Hedland, maybe it's not too onerous on people. But your clinical judgment is always going to form the basis of your decision making, and where you feel uncomfortable, where there is ambiguity, you don't have to do this. Yeah. We did ask about the CASA model as well. Initially, in 2023, in February, they presented me with a form. It was about 8 pages long for GPs to do, and it was based on aviation medicals. And I just said, this is not workable for general practice. So we've sort of been basing things on Ausroads or the driver's license standards, but the CASA form is just too long and couldn't really be done realistically in general practice and a time sort of limitation.
Virginia, you've got your hand up.
Yes, I just wanted to say that I have had I'm rural, and I've had a patient, a well-known patient, come with a suspended license out of the blue. Although at the point of time I examined him, he was physically fit and in a good mental health place, we were then able to explore why he lost this license, and he didn't get it back despite the medical. And we were then able to go on and find out why, and he lost it because of his behaviour at that point in time. And over time, he has come to acknowledge that that's what he did and that's why he lost it. So even though he lost it, he was able to, through his GP, able to talk about it and come to terms with it. I think maybe as a GP, that could be my role with my own patients. I certainly wouldn't tackle it with somebody I didn't know, but this was a patient I'd known for 20 years. And he just had to come to terms with what he'd done. You know, that's not to say that he would not now be fit to hold a license, but it's now been revoked forever. So there you go. Just thought I'd mention that as a role of a GP.
And I guess on that as well, one of the nice things about the assessment is we can actually hand on heart say to our patients that we actually don't determine whether somebody has a firearm license or not. So we can be, you know, a little bit removed. Although the health assessment is part of the process, it's not the entire process. And I think that's just a really good case of point in terms of the continuity you offer and being with the patient as well. So. The specially trained assessors. So look, one of the things that we did talk about was, could there be a panel? You know, could there be a group of people involved with firearms assessment? Why does this have to be, GPs? And basically the outcome of those discussions was, 90,000 health assessments to complete for all these firearms licenses. It was never going to be practicable to have a dedicated board to this. So that's why it was very much put upon general practice.
Yes, and we also asked for a hotline. So when we went to see the minister last year, we asked for a telephone line dedicated for GPs to be able to ring and ask for guidance on these matters, but we were told that yes, there wouldn't really be funding for that. It wasn't practical.
Course, so yeah, I've just seen your comment, Paul. Course that GPs can do to become an assessor like ADHD. I think the first thing is we need guidelines, which are still in the pipeline, aren't they, Mariam?
They are, and we looked at that as well, whether there was extra certification needed, but it was deemed amongst many of us that, and particularly the AMA, that another layer of obligation on GPs, that standard general practice and our clinical judgment is not enough. And so I think really the course to become an assessor for standard general practice wasn't really deemed practicable, and certainly the cost involved, no one would cover that cost. It would come out of our own pockets, and it's just yet another layer of obligation and subspecialisation in a specialty where we're expected to be everything to everyone all the time. Yes, they do force it on ADHD, and I guess that's there are inconsistencies, and throughout the last 3.5 years we've really been up against it, myself and Richard, up against the representatives from WA Police and the ministries, and we fought long and hard for clarity, for that the words fit against standards was removed when there are no clear standards. But there were parts, as Richard said, there were some wins, there were significant wins if we look back to how things were originally presented to us. And it is we who provided clarity to them on the workings of general practice. But there were some things that we could not, no one would capitulate. We considered telling them lots of things, but no, we didn't. No, we didn't.
I think that we had more of an impact engaging rather than not engaging. I think it's like a lot of things. Like we can turn around and say we're not going to engage. It was going to happen anyway, and so really it was a case of trying to work at it from the inside, to be honest, and have those small wins. And I think had we said, no, we're not interested, we're not going to engage, we'd have a very, very different assessment, I suspect. So even though it's not perfect, we kind of stood our ground and stuck with it. Right. Well, I don't know if we've got any more closing comments or thoughts. As I say, we've got the firearm feedback form up on the share screen there, and I believe that's still live. So feel free, and Paul as well, feel free to fire away, and that feedback we can take back to WA Police as well. Absolutely. Oh well. Shall we hand over back to Taylor?
Yes, thank you, Richard and Mariam. That was great. And for everyone here, this has been recorded, so if you ever want to refer back to this, you can visit it at our Rural Health West YouTube channel. But thank you very much to both of you, and we'll end there.
Thank you very much.
Thank you.
Thanks for joining.
Thanks, everyone. Bye-bye.
Okay. Bye-bye.